Fabulous. So, the big forum debate. So this is a debate about bariatric surgery, skinny jabs, diet and lifestyle, common sense, psychological input. So I'm going to hand over to Dr. Matt Capehorn, who's going to chair this session. Over to you, Matt.
Hello, it's a pleasure to be here today, and even though I'm absolutely melting, I'm still going to wear my jacket to obviously hide the Tony Blair style sweaty armpits, but also to try and cover my big belly being here talking about obesity, because obviously I self-identify as a young, thin person still. So these are my disclosures, but the reason why I think today is going to be really exciting is because I've been involved in the field of obesity for over 25 years now. And during that time, I've been a bariatric physician, referring patients to the surgeons. I've prescribed stack loads of weight loss medications, both on the NHS and privately. I'm also medical director of a commercial, very low-calorie diet company, and for the last 20 years, I've been a big advocate for not forgetting about psychological hunger, because there's a big focus, especially in the world of pharma, looking at trying to curb physiological hunger. But you've probably seen lots and lots of different slides like this showing the prevalence and the fact that obesity is going up. There are two statistics you need to remember. Roughly a quarter of the UK population are clinically obese, but 2/3 are overweight or obese. So that means if we're typical of the average Joe Bloggs population in the UK, the majority of us are not at a healthy weight. And the problem is, we know now that obesity is either caused by, causes or worsens over 200 different medical conditions. And so that's why it's so important, and why when I was a young GP, I thought, why are we chasing our tails treating the consequences of obesity instead of the cause? Now, when I first started, people were saying, why do you want to treat obesity? We should be preventing it. Population level public health interventions. Well, when you actually look at this is the Foresight report. This shows all of the different individual factors why we as individuals or we as a society are getting bigger and more obese. But each of those individual little dots are a different factor. There's 106 of them. So when you're asked what one change would you make to cure the obesity epidemic, you can't. So what are we going to do? How are we going to prevent obesity? Are we going to be able to tackle all of those 100 causes? And we haven't got time to debate these, but how are you going to do it? Nanny state or nudge them in the right direction? How are you going to increase physical activity? You're going to go down the route of food taxes or subsidising food? How are you going to do it? There is no evidence worldwide that preventative measures work, otherwise we'd all be doing it. What we do know, however, is that we can successfully treat obesity. Now, why we have black and white, treatment here, prevention here, I do not know, because if we treat the overweight, we're preventing obesity. If we treat the obese, we're preventing severe and complex obesity. So treatment should be considered a type of prevention. And you don't even have to believe me, because it's been done for us. In 2014, the McKinsey report that made it onto the front page of all the newspapers ranked all of the different weight loss interventions in order and looked at the impact on the population and the amount of evidence. And perhaps not surprisingly, the top ones were things like portion control, how much we eat, or the composition of calories in our food. But look where weight management is. I think it's fourth on here, with a huge amount of evidence and a big impact. Look where public health interventions are. You probably can't see on this middle screen, but on the others, you can see it's right at the bottom. And this was in the days of those nice, cuddly, cartoony Change for Life adverts that didn't upset anybody because it didn't dare say the word fat. So now, this is my penultimate slide, but I'm going to spend a minute or two on it, purely because this one slide brings together a lot of the current theories about obesity and what causes it. Now, believe it or not, once upon a time, your mummy and daddy had some time by themselves and managed to get jiggy with it and had a special type of cuddle. And their genes got together and made a little baby. Now, some of those genes will have been good genes. Some of those genes will have been bad genes. But it's not just as simple as that, because we know that the good genes and the bad genes can be switched on or switched off. Now, there's one theory in epigenetics that suggests that what your mother did while you were in the womb influences whether those genes are switched on or off. But not only that, what your grandmother did while your mum was in the womb also influences whether your genes were switched on or off. And it goes back 2 or 3 generations, in which case that might explain the big explosion in the last 100 years. It might not be the food industry, but it also might mean that we're 3 generations away from getting back to baseline. And it might be because for the last 100 years we've been saying to pregnant women, oh, you've got to eat for 2. Oh, you sit down and I'll do all of the washing up, like that ever happened. But things like that. So that's one theory, but then also, what about other things like gut bacteria? Well, we know from transfusions, as they're now called, if you transfer fecal matter from a thin rodent to a fat rodent, the fat rodent goes thinner, starts eating less, and vice versa. If you transfer the fecal matter from the fat rodent to the thin rodent gets fatter. So will we see poo transfusions in the future? But, we don't know how that fits into the picture. Does it influence whether those good or bad genes are switched on or off? Same with chemicals like BPA in milk bottles. Same with the viruses that once every 10 years, the Daily Mail will say, virus associated with obesity. We don't know. But could it all be influencing where your genetic predisposition is, and this is the set point theory of obesity, that we've all got a genetic set point where our BMI wants to stay. And we know that it might change throughout life because there's a theory that, well, maybe puberty, maybe pregnancy, maybe the menopause influences where that set point moves to. But it certainly does explain why some people are naturally thin, some people are naturally on the heavy side. And it also, we now have proper evidence that there's physiological changes that happens when you put weight on or take weight off. When you go on an all-inclusive holiday and you come back a stone heavier and you say, I've got to get that stone off, you find it relatively easy to get that stone off, easier than you would if you're at your baseline and tried to lose a stone. And that's because there's changes to your body. Your ghrelin, your hunger hormone, goes down. Your satiety hormones go up. Your non-exercise activity thermogenesis, tapping and jigging and moving, you do that more to bring you back down to your possible genetic set point. But then equally, when you lose weight, we've got evidence that the opposite happens, that your hunger hormone goes up, your satiety hormones go down. So the secret over the last 10, 15, 20 years has been trying to find ways of perhaps getting us much more comfortable at being at a lower weight, because otherwise, this is why people who have lived their whole entire life with a BMI of, say, 35, 40, can lose weight, they go on a diet, but it always tends to creep back on because they're fighting their own physiology. Doesn't mean to say that they can't keep it off, they're just fighting a long-term battle to keep it off. And we now know, you might hear from some of the treatments, that artificially, whilst you're on the treatment or after the treatment, it will artificially lower that theoretical genetic set point. But I'm not going to spoil the talks that we've got going. This is my last slide. Just a reminder, do not forget psychological hunger. Some of the new treatments will tackle physiological hunger and make you feel more full all of the time. But you've probably all been to a restaurant, had your starter been made to wait 20 minutes for that main course, and actually thought, not really hungry, but because you've paid for that meal, you're going to eat it. So you psychologically override the feeling of fullness. But then, also, you're sitting there properly stuffed and they bring out the dessert menu. So your own gut hormones are telling you that you're full, but you override it because they've just brought out the menu and it's got bird's trifle or Arctic roll or one of your childhood favourites on it. So we've all got that psychological ability to override it. Now, properly last slide, just to introduce the speakers. I'm only going to briefly mention their names. To talk about surgery, we've got Ahmed. To talk about injections, weight loss injections, we've got Eveleigh Nicholson. To talk about diet, exercise, and a common sense approach, we've got Mike Lean, and the psychological approach, we've got Rose Stewart. Now, if they want bigger, longer introductions, they're going to have to do it themselves, but it eats into their 10 minutes. Because I'm going to be very strict. I'm going to put 10 minutes on a timer, and for every 10 seconds they talk past their 10 minutes, they're going to lose a vote at the end. Now, I have been asked just before we start, just to see what the impression is with the room as it stands before you hear the arguments. So who at the moment, and please don't spoil the game by saying, oh, there's a place for all of them. If somebody put a gun to your head and said, you can only pick one. So who would pick surgery? Oh dear, right, okay. You've got a challenge. Who would pick the newer weight loss medications? Wowzers. Told you, Eveleigh. You've got an easy job. Who would pick diet, exercise, and common sense? Oh, actually, there is going to be a debate. Who would pick the psychological approach? Oh, this is great. This is great. And now is the time to hand over to our first speaker who got the smallest vote. Good luck with this. If we could welcome Ahmed to the stage.
Thank you very much. All right, now just watch how this is going to swing around in my favor. Right, so I'm going to put the case forward for bariatric surgery. And the key thing to remember, we're not treating overweight people, we're treating people living with obesity, and usually complex and severe obesity. So that's the remit. We're not going to talk about, for overweight, I would take the skinny jab as well. But we're talking about treating people living with obesity. So this is the case for bariatric surgery. As you're all aware, currently in the NHS, we have the 4 tiers of treatment, and bariatric surgery comes as the tier 4 on top of the pyramid. So what should we offer our patients? You're all familiar with the matrix, so you can either take the blue pill or the red pill, in this case, it's going to be bariatric surgery. So I'm going to give you some of the evidence-based medicine supporting surgery, and this is incontrovertible evidence. We all practice as healthcare professionals evidence-based medicine, so the evidence is strongest in favor of bariatric surgery. And again, in very top-rated journals, New England Journal of Medicine, this is data showing a 30% total body weight loss achievable with surgery. And also, in conjunction with that, you see the improvement in type 2 diabetes, blood pressure, lipid control. So this has all been proven, level 1A evidence. Again, study from Sweden called the SOS study. This is showing a 20-year follow-up. The last study was 12-year follow-up. This is 20-year follow-up. No other treatment here that my colleagues will speak about will show such long-term follow-up of long-term maintained weight loss at 30% with gastric bypass, for example. So, point 1, bariatric surgery is the only treatment offering significant sustained weight loss. There's no argument against it. The evidence proves it. Point 2, what about the impact of bariatric surgery on some of the 200 health problems that Matt mentioned? Well, again, we have very strong evidence supporting improvement and even cure in a number of obesity-related complications. Now, I'm not going to go through the whole diagram. You can see them for yourself, but the key ones, of course, are type 2 diabetes, high blood pressure, ischemic heart disease, polycystic ovary syndrome, infertility, gastroesophageal reflux, joint disease, depression, you name it. Weight loss surgery can usually make it better, if not cure it. This is a list of references, and anybody's interested. Each of those conditions, there's references proving, again, evidence-based medicine that surgery works to improve or cure those health problems. Again, just a summary of some of the key comorbidities that get better with bariatric surgery. Just imagine a 77% cure rate of type 2 diabetes, not improvement, but cure rate. That means patients are no longer taking medications after surgery. What about other problems like cancer? We also know that bariatric surgery has a major impact on reducing the incidence of obesity-related cancers. Again, published in the Lancet Oncology, you can see that in both men and women, if you have weight loss surgery, your risk of getting obesity cancers like ovary, uterine, breast, and GI drops with surgery. And that, of course, we have the risk, the improvement in mortality. So this is again from the SOS study showing that at 15 years, people who've had weight loss surgery have a 30% survival advantage over obese patients who haven't had weight loss surgery, who've used lifestyle measures to maintain their weight. So you get an improvement in mortality as well. And then lastly, we see that there are clear benefits in terms of a socialized healthcare system like the NHS, where, again, we have ample data showing that bariatric surgery is cost-effective and in some studies even cost-saving. And that's why, as you know, NICE approves bariatric surgery for those patients living with obesity. Again, a whole number of references supporting the cost-effectiveness of bariatric surgery. So, ladies and gentlemen, it's very clear, I think. The evidence is irrefutable. Bariatric surgery reduces mortality, reduces the risk of obesity-related cancers, resolves comorbidities, saves money, and of course, patients lose weight as well. Just for those of you who want to know a bit more about bariatric surgery, it's not just one operation. There's probably about 12 different operations. The key ones we do at the moment are the Roux-en-Y gastric bypass and the sleeve gastrectomy. There was a study performed here in the UK last year called the Bi-band sleeve study, which showed that actually in our country, the gastric bypass is probably the most effective treatment at 3 years, giving 27% weight loss and the best improvement in quality of life for our patients. Of course, I'm going to preempt my colleagues who will mention surgery. It's a drastic operation. It's riddled with complications. You'll go in ITU. People might die. It's not true. It's as safe as having a hip replacement, knee replacement, or a gallbladder removal. In this country, bariatric surgery is super safe. The risk of mortality is in the National Bariatric Surgery Registry is less than 0.01%. Early complications of surgery are usually less than 6%, and those complications can occur with any kind of abdominal surgery, like internal bleeding, for example. And late risks typically happen in patients who are not compliant with the post-operative protocol. Yes, our patients do have to take multivitamins, 1 tablet twice a day for life. And if they do that, they'll be fine as long as they're monitored by their GPs. If they don't do that, that's when there's a small chance of 0.2% of getting a nutritional deficiency. But again, if it's monitored by the GP with once yearly blood tests, that's all they need. That can be obviously prevented. Again, some more references for you. Now, I think I should mention this, and I hope Dr. Nicholson will forgive me because I don't want to encroach on her talk. But I think it's only fair for me to make a comment about GLP-1 receptor analogs because there's so much talk about them. You've seen the weight loss I can achieve with surgery. At the moment, the GLP-1s are not near it. With semaglutide, you're probably going to get 12.4%, and that's in the highest dose, which I would say not everybody can tolerate. And same thing with tirzepatide, you can get about 22.5% weight loss, but that, again, is on the highest dose in the clinical trial setting, which does not translate to what happens in real life. So just keep that in mind. So weight loss surgery gives better weight loss than drug therapy. I'm not even going into lifestyle and psychological treatments because their weight loss is around 5%. Outcomes of pharmacotherapy. So yes, they have proven in their STEP trials and SURMOUNT trials they can get short-term weight loss, but no drug trial has yet shown the longevity of weight loss, which my data can show. So you've seen 12-year and 20-year data showing sustained weight loss of 30%. The best studies we have with GLP-1s are probably, I think, 2 years or 3 years long. So long-term weight loss with GLP-1s is unknown. Again, there's very little data on improvement in comorbidities. Obviously, the diabetes gets better with the weight loss, and there's obviously one trial showing improved cardiovascular mortality with GLP-1s, but we don't have any of the other information we have, as we do with weight loss surgery, about improvement in all the other health problems that go along with obesity. And lastly, we don't have any data on GLP-1s about reducing mortality and reducing cancer risk. So most patients, if you ask them, what really worries you? Is it dying prematurely? That would probably be on top of my list. So if that's a concern, have surgery. And lastly, yes, of course, drugs are a non-invasive treatment option, but who's going to take 1 injection a week for the rest of their life? That's a whole other question. And you can see from, again, the STEP trials, once they stop taking the drug, their weight comes back on. And don't forget, it is also, there's a cost element to it. So this is long-term treatment. So it'll be for years and years and years, and those costs will probably add up to more than the cost of an operation. So we know at the current prices, you're probably spending about £2,500 on GLP-1s per patient per annum. Your average bariatric surgery costs about £6,000. And then, of course, I can't not mention the popular press and some of the horror stories we've seen recently about the other side effects of surgery, of GLP-1s that are coming up. So stomach paralysis, unbearable side effects, wrecking their bodies, and one study even showing that it results in very little fat loss. The one thing that I should mention, which is coming up, is the fact that when you take GLP-1s, you lose more muscle than fat, and that's a real concern. So just keep your eye on that. Right, I think I probably, is it my 10 minutes? If I have...
You've got 60 seconds left if you want to sum up.
Fine, excellent, okay. So challenges with medications, not all patients will achieve target weight loss. Side effects can lead to poor compliance. Rebound effect when you stop the injections. No long-term data. Availability, how many of your ICBs are actually allowing people to have GLP-1s? Big problem. Bariatric surgery, yes, it is NICE approved. And lastly, cost effectiveness. So, ladies and gentlemen, if you're in the matrix, which one do you go for? You go for surgery. Thank you very much indeed.
Excellent timing, I have to say.
Do I get 5 extra votes for finishing early?
There's going to be no opportunity for questions until later. Now, all of the speakers, once we've heard all of them, will get a couple of minutes to criticise what any of the others have said. So it should be interesting. But if we can thank Ahmed. And invite Eveleigh up to the stage to talk about weight loss medications, or the skinny jab as it's advertised.
So, somebody woke up and chose violence, didn't they? Hey. So one of the fun parts of doing a debate like this is you don't get to see in advance what your peers are going to say. So, being the nice, generous person I am, I decided not to attack other people's modalities of treatment, but I may yet change my mind on that when we get on a little bit later. Now, in terms of who I am and my disclosures, so I work in Portsmouth. I'm a diabetes and endocrine consultant, but I also work in both a Tier 3 programme out in Portsmouth community, and I work with surgeons who I used to like in our Tier 4 bariatric service as well. So I was going to advocate for all modalities of tackling obesity, but I'm not so sure anymore. Again, unfortunately, Matt has tried to steal everyone's thunder by doing a lot of slides that I would have done. So on the plus side, I'm going to be quick, and I'm hoping I will accrue additional votes as a consequence. Good. These are my disclosures. So this is going to be a bit of repetition based on what Matt said, but I just want to make sure everyone's really clear that weight is controlled by really complex, multiple mechanisms. So individual psychology, there's a really good quote from Kate Moss that says, nothing tastes as good as skinny feels, all right? So how you value your weight has an impact on what your weight is. Social psychology, including culture, what do you like doing? Do you like going out? Is food part of your social life? Is that what your friends like doing? Culture, different cultures across the world look at weight in different ways. Some cultures very much value higher weight because it's synonymous with higher social status. Your environment, now I've seen Paula around, so I'm from Portsmouth originally, I don't just work there, so I always pick on Southampton when I talk about environment. You know, you walk down some streets in Saints and it's a kebab shop followed by a convenience store, followed by a chippy, followed by a pub. You know, what actually is around you in terms of food availability? Your individual physiology, it's my genes, doc. Your microbiome, Matt's already talked about. Do we understand it? Nah, not really, but we know it's important. Your social status, the lower your socioeconomic status, the more likely you are to be obese, and the more likely your children are therefore likely to be obese. Your food consumption, production, and availability. No longer do we have our own allotments. We grow our own food. It's all fresh and available. We don't keep our chickens and get our eggs. It's import, it's export. Now, Iceland, inflation. But Iceland used to do a £1 meal, which was a giant Yorkie with a chicken curry in it. Yeah, banging. £1. All right? Nowadays, it's actually £2, which is very expensive. A punnet of strawberries, £4.99. If you are a low-income family, what are you going to choose? Do you choose to feed your family? Do you choose to feed your children? Or do you choose the strawberries? And we have to be realistic about that. And activity, how much it changes your own personal metabolic rate, how physically capable you are of doing it if you are morbidly obese. I always tell my patients, exercise is not going to the gym and wearing Lycra. It's just simply doing something enough to make you feel a bit hot and sweaty, but that's uncomfortable for people. Told you Matt's stolen all my slides. I wanted to show this simply to, again, emphasise the complexity of obesity. But in particular, right in the middle there is those real central tenets of what controls an individual's weight, okay? And the effort to acquire energy, so that's like, did you have to run out and kill the woolly mammoth yourself to eat it? Or did you ring DoorDash, where they will quite literally come and put food in your face for you? And I've got patients who do that, and they have a lockbox and people walk in, they know them all by name. So, all of these things have changed over the years. It's the gene stock, it's my genes, isn't it? So, heritability of obesity. That food choice, are you sweet or salty? Both. Satiety, how full do you feel? Do you get satisfied by food? I've got colleagues who can eat a finger of Kit Kat and they're done, thank you. I want a pack. I want them all. But that's because they genuinely feel full. They eat to live. A lot of people now live to eat, myself included. Reward. Are you sex, drugs, or are you rock and roll? Our brains light up for different things. We feel pleasure from different things. For some people, pleasure comes from food. Exercise, again, how you respond to exercise, what your metabolic rate does with it, how your hunger or satiety are driven by exercise is different. Fat distribution, is it under your skin? Is it around your organs? Are you an apple or a pear? You don't get to choose. You don't eat a biscuit and go, can you just stick it around my legs this time? Your weight goes where your weight goes. Response to dieting, and we see this. Some people do better on a 5-2. Some people do on a very low calorie. Some people like intermittent fasting, and different things work for different people. That's your response to dieting, what your hormones do. And circadian rhythms, again, the importance of sleep. Can't emphasize enough how important sleep is. So here's some fancy hormone stuff that I don't really understand, if I'm being brutally honest. I just know that they're important. But you have actually far more hormones that work towards inhibiting your hunger and stopping you eating than you do than stimulate it. But oxytocin right there in the middle, that's your pleasure one, that's important. And as Matt's already said, cheers Matt, your body weight is defended, all right? So when you lose weight, your body will do everything to bring it back to where it thinks it is or should be. So this is your homeostasis. Don't worry, you don't have to look at it all. But the point is, all those different hormones, your food-seeking behaviours, all those things, all work together to keep your body in stasis at whatever that weight is. And when you balls it up, i.e. you lose weight, your body goes into panic mode. And this is evolutionary. We grew up in feast or famine world. You killed a woolly mammoth, you ate it, you sat in your cave for 2 months. Those skinny minis whose metabolic rate was too high, they died. Those of us, count myself in there, who could slow down their metabolic rate, who could suppress that hunger and just basically stick with it, survived. And that's who we evolved from. All right, so we're survivors. Cockroaches and spam, we're all there surviving. All right, so your body will do everything it can. It's panicking. It thinks it's famine. So let's feast when we can. We'll drive you to eat. We've already said, obesity is a gateway for 200 plus diseases, medical, surgical, psychological. It's so incredibly important we get to this and we get to it now. So, Mr. Ahmed doesn't like these drugs, but hey-ho. So let's think about these drugs. Okay, so we've got liraglutide, which at 3 milligrams is advertised as Saxenda. This is really the first one on the market that showed about that 6-7% reduction in weight, which then and still is better than, and since he fired shots, I'm going to do it as well, is better than sort of our standard diets, which often show about 5%. And then we had semaglutide, more like 16%. That's not bad, is it? Most people would take that. If you offered them 10 to 15% weight reduction, they take it. And actually, there's plenty of evidence that says if you reduce your weight by 5%, and if you're lucky, 10%, you reduce your blood pressure, you reduce your fasting cholesterol, you reduce your fasting glucose. Any weight loss is good weight loss, so this is already good. And then it's 25%, honestly, 22. Now we're getting the big guns out. So this is tirzepatide. Yes, this is the highest dose. Yes, there is dose-related weight loss. So your weight loss at 15 milligrams is unsurprisingly better than it is at 5 milligrams. What, of course, you don't get told is if you compare this to the BIBAN study, when you're looking at a gastric sleeve, the weight loss you're getting with tirzepatide is very comparable. Okay? So this is my last slide because I'm quick. Let's get real. All right? We work in the NHS. The number of bariatric procedures that has been done in the last few years is static. Our obesity crisis is going up. As of this year, more bariatric procedures are done abroad on UK residents than we managed to do domestically. Right, if we're talking about tackling obesity at a true population level, you tell me what we need to do. We cannot wait 3 generations. We have to do this now. If we want to be the grandmothers whose grandchildren are not obese, we can't wait for that turnaround. We have to do something. And we know there aren't enough psychologists to support every person who's obese. 25% of the population dream on. We know that in reality, because diets have been around for a very long time, they ain't doing the job. Otherwise, the proportion of the population that is obese wouldn't be going up. So what can we do now? What can patients achieve now that will allow them to get weight loss? And I think as much as I would advocate for bariatric surgery, and I do, that's why I do the job I do, in terms of what I can offer a patient today, it's got to be weight loss injections. Thank you very much.
You only had 10 seconds to spare, so no free votes at the end, I'm afraid. One extra vote. No, not one extra vote. Right, thank you for that. So our next speaker is Professor Mike Lean, so let's welcome him to the stage.
Thank you, and I've enjoyed today. I've learned all sorts of interesting things. Matt accused me of being the most risky speaker of the lot because I'll have so many slides that I'll run on. So I'm going to show you just one slide. And if we can have, there might be an introduction. Can I switch it on? Can you switch it on? Forward. There we go. That just says who I am and some disclosures. And there's my, cheated, one slide. We are here today to talk about obesity. As a physician, diabetologist, obesity to me means a step into a whole raft of metabolic disorders, which is why we're really here today. It's not just because people look bad or even because it's inconvenient. And we're really dealing specifically, in my mind, with type 2 diabetes. I'll just put some figures up there. They're figures you know about from Nurses' Health Study. By the time you've got a body mass index of 25, your risk is up already 5 times. If you get to a BMI of 30, your risk is up 40 times. This is a crazy association which is driving a huge disease. If you develop type 2 diabetes, currently it will reduce your life by 5 to 6 years, your life expectancy, on average. If you get it below the age of 40, and this is data from a big European study, it will reduce your life expectancy 15 years. We don't tell our patients that, do we? Why not? They're already coming to us asking us about the solution. They don't actually want diabetes, mainly because they've heard it's bad for you. And of course, you don't die sharply and cleanly in your bed. You die with multiple complications, which are disabling and painful. This is a very bad disease. So I think it's important to reflect on that aspect of why we're here. There you go. It is the same disease process. In my book, obesity is that disease which the WHO tells us is of an accumulation of excess or abnormal body fat with medical complications. And it just so happens that if you're genetically predisposed, then that obesity disease is going to give you the features of type 2 diabetes. And it's caused by weight gain. It goes absolutely conclusively caused by weight gain. And I remind myself that, when I was a medical student, we had something called ideal body weight. And then we were told never to use this term because it apparently castigates everybody who's not ideal. BMI of 18.5 to 22 is the best functionally if you want to get out, climb mountains, kick a ball, enjoy fun with your kids, grandchildren. It's best for your cardiometabolic health, for your physical health, and for your mental health. So that concept of ideal body weight is probably something we should revisit very slightly and not be hoodwinked into accepting BMI of 25 as normal. It isn't normal, or even 23 probably. Thing's not working now. There we go. And what we did in the direct trial, I'm not going to bother to show you all this because we've done it before and before and before, was to show that with quite modest weight loss, according to the surgeons, we were able to turn around type 2 diabetes in a major kind of way. The intervention we used was a diet program, a composite diet program called Counterweight Plus, which is still available. Actually, it's now better because it's been made digital and remote, and you have to go anywhere to get it. And what we showed was an average weight loss of about 14 to 15 kilograms, which is not ideally maintained long term. It's maintained not badly. 1 year and at 2 years, both at 1 and 2 years, over 80% of people with type 2 diabetes were free from diabetes, off medication, no longer diabetic. And we've gone on to show in the 5-year follow-up that people who achieved remissions of their diabetes were then progressively freed from the complications of the disease. It makes sense. If you don't have diabetes, you won't get its complications. So go for it. And that's what a lot of our patients are doing. Thankfully, through Diabetes UK, they actually want remission of the disease. They don't want to take medications forever, which won't actually stop the complications. Weight loss is negative energy balance. You can only get weight loss if you eat less calories than you're burning up. Some people find it easier with a lot of physical activity. Most people don't find the physical activity helpful at all. And for people with type 2 diabetes, it's often impossible, and it's a waste of time and energy to try and pursue that line. The diet, when you boil it down, thankfully, we've done lots and lots of research with systematic reviews and evidence-based recommendations. The macronutrients don't matter. It doesn't matter how much fat or carbohydrate or protein there is. What matters is the calories. You need to optimize, as best possible, the micronutrients, the vitamins and the minerals. And the best way to do that, whether you like it or not, is with formula diets to induce the weight loss, because they come out of a packet, you can't go wrong, you don't come back for second helpings. And that's what's worked best in clinical trials, although we do now have evidence from other studies that dietary approaches with about 800, 850 calories a day can be tolerated without inducing a lot of hunger in the short term, which is interesting. Our patients don't complain about hunger. We don't do it alone. Of course, we have support from what broadly would be called psychology. Diets don't happen out of the blue. You need to persuade people to do what you want them to do to help them through the emotional difficulties they may have. So psychology is an integral part of this, and the human support is clearly vitally important, especially for emotional eating, which is a big problem. The GLP-1 agonists and their related drugs, what they do is help people to adhere to the diet programs that we're recommending. They don't do anything else. On their own, they don't cause weight loss. What they do is make it more likely, more possible to stick with a diet program. So all for them, they're great. And you'll notice that all of this requires good diet in the first place. Psychology alone, bless them, doesn't do anything much. You've got to have a diet to work on. The drugs alone do nothing. Have I missed anybody out? Oh, Mr. Ahmed. There you go. Wonderful. Surgery told us that weight loss was effective. We've learned a huge lot from bariatric surgery about what can be achieved with effective weight loss. And they can get weight losses of 25%. That's fantastic. They turn up in my clinic with all the complications for years and years and years and years, especially those who are driven to Turkey and Belgium and Costa Rica, and their operations are done in hotels someplace, and God knows what is being done to these people, but they come back to our intensive care units because we cannot offer bariatric surgery to everybody with obesity or anything like it. And that's the end of my one slide. Have I run out of time?
You haven't run out of time.
No,
You've still
and the
got
risk
3
here,
minutes.
there are now, I think, 3 more slides, but the problem is they got pushed down the presentation pack and I can't get at them. So what I'm going to have to do is take a break, with your pleasure.
Very well. Seeing
I've never
as
done
it
this
isn't
before.
your fault, the order of the slides, then
And
you can have 3 minutes back.
And
Only if you stop now. As a GP who obviously likes to hug trees, I would like to point out there is still a benefit in physical activity for cardiovascular reasons, perhaps not the weight loss. Right, on to our final speaker, Rose Stewart, who is going to talk about the psychological aspects of weight loss.
Ah, elderly white medics, bless them. Right. So, I'm a psychologist working in health services, which is something quite unusual. And as a psychologist working in health services, something that I have seen over and over again, both in my clinical world and in the research, is the absolute carnage that medics and medical researchers thinking that they can have a go at something that is clearly a lot more complex than a biological issue has caused. Do we need to mention lobotomies? Do we need to mention women being forcefully sterilised? This is something that is not about a biological process. This is something that is much, much bigger. And it's interesting that my learned colleagues couldn't get through any of their presentations without outlining the importance of psychology. But we don't need to go through that. We don't need to start throwing stones at these poor, vulnerable people. What we need to really be thinking about in this room is your experiences. Because I don't need to give you research methodology. I don't need to give you stats. I just need you to participate. So by a show of hands, please show me, and please be brave, and please be honest, who has felt unhappy because of their body shape or weight? Okay. By a show of hands, during times of stress, have your eating habits changed? Okay. Again, by a show of hands, think about a really difficult time of your life. Think about what you went through in COVID. Think about some of the most difficult things that happened to you. Did your body shape and weight change? By a show of hands, have you had somebody make you feel bad about your body shape or weight? I'm going to get in trouble. I got in trouble last night for swearing in my presentation. I'm doing it again. Fuck the people that made you feel that way, because that is not okay. Okay? So we know that weight management is something that is complicated. We know that it is something that is tricky. If it was something obvious, we would have fixed it a long time ago, because we've known for a long time that this is an issue. So we know that there are really complex interactions. Interestingly, that really complicated foresight diagram, one of the factors that's strongly indicated on there is women working. You need to get back in the kitchen and cook stew and stop giving your kids microwave meals. Now, is that likely to happen? I think not. Okay. So we know that weight management difficulties come with lots and lots of complicated things. We know that this is something that is not as basic as your gut hormones, and reducing it to that is doing people a real disservice, and it is not going to work on the basis that we need it to. Now, we know that there's really strong evidence for the psychological side of things, not just to do with the choices that we make, whether we exercise or not, but also our histories. We know that if a person has been through adverse childhood events, so these are traumatic events, these are things like neglect, these are things like difficult parenting experiences, the rate of obesity in people with multiple ACEs, adverse childhood events, it goes up 46%. This is absolutely enormous. This is a worldwide epidemic. So if we're not talking about trauma, if we're not using trauma-informed care, we are not seeing the whole picture here. And if we're shoehorning people into scary, difficult, again, traumatic experiences in our NHS settings, like surgery, without that consent, without that follow-up, without that care, we will re-traumatize them. We will make things worse. Again, a lot of the narrative from the medics is looking at telling people off, educating, berating people, and forcing them into these situations when we know that there's really strong evidence that weight-based stigma, weight-based shame just creates more stress, just creates more eating and more cortisol and more weight gain. Now, cortisol is one of the most important hormones that you will hear about today, because when people are chronically stressed, that leads to chronic inflammation, and people will, A, emotionally eat, and they will, B, retain more weight. Stress and trauma directly impact on the ways that our bodies work, and if we don't work with that, none of these interventions will work. So, our friends, the psychological interventions. So, what you'll find when you're looking at the big RCTs is that psychological interventions aren't often on there. Now, one of the reasons for that is when I do therapy with people, every single intervention that I use is personalized. So if Beth comes to see me, the intervention that she will get will be completely different from Amanda's. They're different people with different experiences, with different needs. Every intervention I provide is different. Now, that is never going to fit into an RCT. I am never going to be able to apply these levels of scientific rigor that the medics set onto the studies that I do. So you will not see enormous RCT manualized control studies of psychological therapy, because every person we see has different needs. However, we know that there's really strong evidence for all of these therapies. So we've got the old school CBT, we've got interpersonal therapy looking at those relationships, and then we've got our third wave therapies, which is the ones coming through now. So mindfulness-based therapy, acceptance and commitment, DBT, that's looking at emotional regulation issues and how you can replace those eating strategies with more adaptive behaviors. But one of the beauties of psychology is that it's not just giving you a tablet and making you go away. It's looking at those underlying issues that underlie the behavior. So what are the things that drive this? Is this a really adaptive stress coping mechanism? Is this a way that I get to keep people out? It might be that we have particular beliefs, so beliefs about those generational issues. So my mum was fat, my grandmother was fat, I'm destined to be fat. I was fat as a child, this is how I am going to be. We also know that there are some really significant payoffs in terms of emotional regulation. When I feel sad, carbonara is my friend. It helps me in many ways. Similarly, cake. So it's these things that we know are really, really important for us emotionally. And if we are not able to have those things, then real harm can be caused. It was really interesting that of all the benefits that Ahmed had in his slide, what he didn't talk about was the increased risk of suicide in people post-bariatric surgery. If we cannot replace those emotional coping mechanisms, people will suffer. What we also get with a psychological therapy are those long-term things. So when people come to see me for therapy, they don't just learn something that's going to help them for the next week. They learn things about themselves that will last for the rest of their lives. These things don't go away. So it's looking at that lifestyle change right across the piece. And we know that it's not just the individual in lots of these circumstances that needs a weight management intervention. For lots of the people that come to see us, it's an entire family. It's looking at their parents, it's looking at their partners, it's looking at their kids. We know there's really strong evidence that the whole family often needs to change, and that obesity happens in a system, not just in an individual. So psychology can develop these skills to enable people to do that. It also gives people that insight and understanding. They understand why this is going on for them, and it undoes some of that really difficult shame and stigma. What it also does is it builds self-efficacy, a person's belief and confidence that they can manage this and feel better about themselves. And these are all skills that transfer out into multiple areas of life. So this is not just that you get amazing weight management skills from coming to psychology. You also get loads and loads of additional bonuses. So we're not just looking at weight, we're fixing your entire life. None of those people will do this for you. We also need to seriously think about the risk of adverse effects. As we know, with the skinny jabs, we don't know what those adverse effects is, but a major one is going to be the proliferation of the pharmaceutical industry into the UK NHS and how much that is going to cost. We're also looking at the adverse effects of surgery, whether it is people coming back from Turkey with horrible infections and missing a kidney, whether it is to do, yeah, it happens, whether it's to do with the massive increase in depression, anxiety, and eating disorders that we find, or whether it's to do with people's lives changing so dramatically in a way that they were not ready for, that actually life is a lot worse for them post-intervention. Psychology is not going to do that. The worst that you will get from coming to one of my sessions is that maybe you cried a bit hard and you didn't really like it. That's a lot more reversible than losing a kidney, believe you me.
That's a very good place to stop, unless you want to lose votes.
Okay. I'm going to lose a vote. I will
You
forfeit
wanna
a vote.
lose a
I
vote?
will forfeit
Okay.
a vote. Finally, when we are talking about the policy side of things, when we're looking at societal change, whether it is to do with persuasion, restrictions, who's going to convince the politicians? Psychology.
Thank you for that. Mike, do you want your final 3 minutes before we come back to arguments? They can do it. They can do anything. That is. Blimey.
Psychologist runs off with microphone. Aha! I made this slide up yesterday, not knowing what we were going to be hearing about this morning and our communications with Sierra Leone. The think before you vote is the call for common sense. Over 80% now of people with type 2 diabetes live in low-income countries. And this little badge here tells you I've just been working in Nepal. I work in a hospital in Dhulakal. I came back last night. And these are some pictures, jolly pictures, to tell you why people have diabetes in Nepal who didn't have it a generation ago. And the question really is all our work on obesity and type 2 diabetes going to help anybody in Nepal or Sierra Leone with type 2 diabetes? And should it help them? Should it help them, or should we just ignore it? Well, the project we have in Nepal has finally been funded through the Global Alliance for Chronic Disease. It was not even read when I submitted it in 2021, because somebody called Rishi Sunak declared that the public money that you're giving to the taxman should be used to be redirected towards Michelle Mone and her friends, and they stopped the funding for development in ODA development. So that project was not funded for 4 years purely because of Mr. Sunak's decision. Some of you probably voted for him. I'm in England. I know that happens in England. I don't want to see you. No. I'll close my eyes. Right, there you are. That's a health centre. There is going to be no bariatric surgery in this health centre ever, nor in the hospital in Dhulakal down the road. There will never be GLP-1 agonists at all, ever, in this country. They can't afford anything more than metformin. And that's what they get, 500 milligrams once or twice a day if you're lucky, and no other care of any kind. We've just finished a pilot study, which was published in The Lancet 4 weeks ago, which used a totally traditional diet program. It's wonderful, rice and dal bat, which everybody likes, everybody loves, in the right amounts. We can get weight loss, not a huge weight loss, but we've knocked hemoglobin A1C down to 6.7% in people who were treated with 2 or 3 drugs in the hospitals in Kathmandu. Remission rate, 43% at 12 weeks, 39% at 24 weeks, 29%, still almost 30% at 12 months. This is a beginning, unfunded, completely unfunded, thanks to Mr. Rishi Sunak and his pals. But the day before yesterday, we've started a project which is going to be running for 3 years in the communities to see what we can do with a bit of encouragement and education and collect data. So my plea to you is vote with common sense. And what we really need worldwide, more than anything else, is an evidence-based, reliable dietary weight loss program. You need that after bariatric surgery. Late weight regain is a huge problem. A lot of our patients after bariatric surgery are now on GLP-1 agonists because they keep gaining weight. We need it to stop the GLP-1 agonists. We can't carry on giving these drugs forever and ever and ever. We need a diet program to pick it up and maintain the weight loss. We've shown in a pilot study in Glasgow that can be done. And we certainly need it after diet alone weight loss. And I think that the funding to do this should begin to match the funding, the billions and billions of dollars being put into drug development and the threepence halfpenny that's still going into bariatric surgery. Thank you.
Jolly good. Now, don't go back to the table. We've been given these chairs for one reason only, to get all 4 speakers up here and to have, we're going to make it 2 minutes each to either sum up your arguments or rip into the other speakers. Now, you've been making either loads of arguments on that piece of paper or a shopping list. So have you. So, right, we'll start with Ahmed.
All right, thank you very much. So ultimately, in the NHS, we have a fixed pot of money, and we have to find the most evidence-based way of using it effectively. And I think, without a doubt, I've shown you from my presentation that the evidence lies with bariatric surgery. You've seen it gives excellent weight loss, very good improvement in obesity-related complications, the only modality that offers increased survival benefit. So what we need to do is not to have our patients go to Turkey for surgery, but we need to increase the amount of bariatric surgery being done in this country. I agree with all my colleagues, we don't do enough. That's what they were saying. Even they're saying we need to do more surgery, and that's right. We do about 5,000 a year. It needs to go up to at least 20,000 a year, if not more. In Europe, we are the lowest penetration of bariatric surgery. Just a few words on Dr. Nicholson's presentation. I mean, the whole point with the GLP-1 drugs is that the evidence just isn't there to show any long-term weight loss with them. The studies are short-lived. We don't know about the compliance with these drugs long-term. The costs are going to be astronomical. And what about the long-term side effects? Don't forget, these GLP-1s were causing thyroid cancer in the initial animal experiments they were done on. So there's probably going to be a lot more complications that we're going to see with GLP-1s. And the cost of using GLP-1s lifelong on patients is going to be astronomical. Wanted to make a comment on Mike Lean's talk as well, if you don't mind. I think his diet intervention is fantastic for treating type 2 diabetes. I agree, only need a moderate amount of weight loss. But the remit for today's debate was not what's the best modality for treating type 2 diabetes. It was how to treat patients living with obesity, or the big obesity debate. So that's why I think dietary interventions are not going to cut it for people who are living with obesity and its complications. And lastly, with Rose, great talk, lovely personal opinion, but I didn't see a shred of evidence presented about the impact of psychological interventions on percentage weight loss, percentage reduction of diabetes, percentage reduction in mortality and cancer incidence. So I think evidence has bariatric surgery in its favor. Thank you very much.
Excellent timing again. Right, so Eveleigh, over to you for 2 minutes.
I feel personally attacked, by the way, so I'm not going to bother standing. So, for the record, and I didn't say this at the beginning, I hate the term skinny jab. I really do. I didn't choose that title, by the way, I was given it. It's very Daily Mail headline, okay? And I hate it because when you trivialise a treatment, you demean the patient, all right? And that's why I don't like it. We don't call, the monoclonal antibodies we give for eczema the anti-scratchy jab, or the ones we give for asthma the anti-sneezy jab, all right? So I don't like that one little bit, because apart from anything else, these people will never be skinny, okay? It's definitely mis-selling it. What for me the really sad thing about today is, and I mean this seriously, is this isn't a debate at all. People living with obesity need all of these interventions. They need all of them, and they need them on rotation, and they might need them lifelong. So the fact that we're asking you to choose between them actually is thoroughly mis-selling what we should be doing for people living with obesity.
Don't spoil the game.
Sorry. I'm an anarchist and I want to spoil the game, because actually it gives the wrong message, doesn't it? That somehow you should be choosing one or another. And actually you shouldn't be. We should be able to offer people living with obesity all of these interventions. However, if you do have to vote, can I suggest you vote for me? And the reason why is we cannot afford to do nothing. Okay, we can't, because the obesity epidemic is only getting worse. So vote for the thing you can do, and that's therapeutics. Thanks.
Very good. And sticking to time, Mike, 2 minutes.
Okay, I think I'd like to give my vote to Rose for one reason only. Well, for many reasons, but she was the one who actually said that if we are going to get anything to happen, to come out of all this, it has to work through politics. We have to get politicians on board. And offering them surgery to change their minds isn't going to work, chum. We can stick as many pointed needles into them as we like, and we do, and that hasn't worked. I think psychology is our only hope in persuading our politicians to actually come on board. And I never, ever want to be in a world that sees our Rishi Sunaks, cutting essential treatments that really make a big difference to real people in the real world to favour pals who are making fake whatever it was she was making. And that's the end of my political diatribe for the day.
Excellent.
We all know, of course, that common sense is going to win at the end of the day, but it works through common sense and psychology. Brian.
And I thought Obi-Wan Kenobi was our only hope.
So you've got one vote.
Thank you, Mike. That's the vote I forfeited, by the way. So ultimately, when we are talking about weight management, we're talking about behaviour. We're talking about the need to change behaviour. And there are interventions, whether it's therapeutics, whether it's surgery, that forces people in a very brutal and risky way to do that. But we're thinking about behaviour on a massive scale. So whether it's the choices that you make in the supermarket, whether it's deciding to put your trainers on, whether it's feeling like you can go to the gym and belong there, even though that horrible sweaty man will not stop looking at you. It's all of these things, but it's behaviour on multiple levels. It's also about the parenting decisions that we make. It's about the school dinners that we feed our children. It's about what promotions can happen. It's about what food gets advertised to us. All of these things come down to behaviour change. Which part of the body do we use for that? Our brains. What does psychology work with? The brain. So I would very much implore you to use your brains and think in that way. In terms of the evidence, once again, I would point to the enormous bias that medics seem to have in this field and the way that studies are designed. And I would remind you to think of the evidence in this room. Think about your own experience. Think about the experiences of your friends, your families, the people that you love. This is a very, very difficult situation for people to live in, but this is something that we can certainly support and we can work on multiple levels with a psychological approach. Thank you.
Very good. Now, with all four of you sitting up here to make sure that I'm not skewing the result, we are going to ask everybody to vote once and for only one. So I don't know whether you can do it by scanning your QR code, whether you've already done that. And then hopefully somebody very clever at the back of the room somewhere will present the results on the screen, I hope. Wow. Now that's very different from the scores at the start of the day. Now, is that a success for Rose, or is she going to credit Mike with a little bit of that?
Does it mean I'll now get to earn the same as Ahmed?
Well, it looks like despite the fact that you can now go to a private clinic or very soon go to your own GP to get a weight loss injection, you think that it's the mind that's more important. So when you go home, remember your stomach is only that big. So when you've eaten that much food, you're going to stop and be full for 6 to 8 hours. And when Coronation Street or EastEnders is on, you are not going to head to the cupboard and go for a chocolate bar or a cream cake because that's just psychological hunger. And you've learnt today that's not the answer. So thank you for all of our speakers. They were all absolutely fantastic. And thank you all for listening.